name is Dickson Wu, and I'm from North Shore University Health System. It's in the Chicago area. We have 4 hospitals. We do Evanston, Glenbrook, Skokie, and Highland Park. I'm going to discuss today our use of the femoral nerve block and catheter. First of all, that's my obligatory family photo. That's me, my wife, and my 2 kids. And most important is my mother-in-law, who usually takes my side, so in any arguments. What we use a femoral nerve block for at our institution, the main ones are for total knee arthroplasty, which is what we usually do a fem block for. We also do them for ACL repairs, and it's surgeon dependent. One of our surgeons likes a saphenous block, one of them likes a femoral catheter to go home with. I'll discuss that in a bit. Also, we will do it for a medial foot and ankle surgery in conjunction with a sciatic. Sometimes we'll do a saphenous, but sometimes we'll do a femoral too, and what I call saphenous rescue. I'll get into that later on. Just a reminder of the basics. It's the anatomy. It's the femoral nerves off of the lumbar plexus. The branches L2 to L4. There's an anterior and a posterior division. The anterior division has the muscles of the pectineus and the sartorius. The posterior has the quad and a lot of the sensory aspects of the knee. Just another basic photo of basic anatomy. So you have your vein, which is medial. Usually on ultrasound it's compressible. You have the artery, which you can readily see, which is very easy. The nerve sometimes you don't see, but it's like a triangle hyperechoic structure, and many times you can't see it right resting up on the iliacus muscle. The way we like to position our patient for a femoral nerve block is supine, with the legs slightly abducted. If the patient's a little bit bigger, sometimes you will have to deal with the pannus somehow. We do try to get the target. We try to get under the fascia iliaca. I like to get under it and peel it off the iliacus muscle. I like to split my local dose. I go below first and then above later, and then I put the catheter below. Some of the dangers of this block is obviously a vascular puncture, and the femoral nerve a lot of times has been implicated in many cases. There's some neuralgias, so I definitely try not to even touch the nerve with the needle. I hydrodissect around it. The location of where we do the femoral block, we like to put the probe right at the femoral crease. You can see that right here. That's where we usually put the probe to look for our structures. When you get this view, here is the femoral artery. Here's the femoral vein. That's usually compressible. Here is the nerve. Here's the iliacus muscle. Many times if you're too distal, you'll see the profunda splitting off, so I usually go proximal until you see the femoral artery as one structure. If you go way proximal, then the femoral artery goes deep. We usually try to take it where I had before, right there in the femoral crease. The target, again, I like to come in with my needle here as now this arrow is a little deceiving. I come in somewhat a little more flatter, and I like to peel this femoral nerve off of the iliacus muscle. I usually enter here and have the local between the iliacus muscle and the femoral nerve, and I'll hydrodissect with little increments of local underneath here, and then I'll go back on top. Usually we use 20 cc's of 0.25% bupivacaine, and we'll peel off the nerve off the muscle here, and then I'll go on top and put 10 over the top. This video that we've taken is probably not the most professional video, because we did it with a handheld video camcorder, but that's me. we use our femoral block with the ultrasound-guided femoral block. Obviously, you need an ultrasound machine. We use a high-frequency linear probe. We use a Aero epidural kit. We use a ChlorPrep for the prep. We treat it just like a neuroaxial block. So we prep and drape sterile, hand washing. There's our 20 cc's of 1/4% marking and probe cover. I do 30-second prep with the ChlorPrep, especially dig in there in the femoral crease because it is one of the places that the potential for an infection is there. So I actually have when I do it, when I have the resident, I actually do have them watch the clock exactly, and I won't let them just scrub a little bit. I do scrub it for 30 seconds. Here again, the patient's in position with the supine, with the legs slightly abducted. When I place the sterile drape cover over it, I only peel the sticky part off the top, but the hole where the needle goes, I do not peel the sticky thing off because I've had the catheter stick to that and pull out. Here's the sterile probe cover going over the probe. I also gel over the probe before I put the sterile probe cover. This is a two-man operation most of the time. Sometimes if I am by myself, I'll put a sterile cloth so I can adjust the ultrasound. As you see, I put the probe in the femoral crease. I'm coming with my 1% lidocaine local from the epidural kit. I try to take a lateral approach from at least 1 or 2 centimeters off the probe and go through the iliacus muscle so you get a nice bite of the muscle. And so you can take a flat angle so you can see the needle, and also that bite through the muscle tends to hold the catheter as we don't tunnel it. Here you can see the femoral artery, here's the nerve, here's the iliacus muscle, and the TUI needle from the epidural kit has an extension and it's hooked to the local, and I hand that to the assistant. And again, we're trying to take a flat angle. The local is like a finer needle, and it also contrasts the needle when you put the TUI in. Here you can see the end of the TUI at the iliacus muscle, and as I'm injecting local, you can see it peeling the nerve off of the iliacus muscle. And so I'll usually put 10 cc's underneath it and try to peel that whole nerve off, and usually you can see the nerve much better after injecting the local. You can see again some more separation. After I have injected the local, I will let the probe down and I'll hold the needle. Later on, I'll have an assistant grab the probe. I'll take the catheter, and I usually have the catheter pointing up since the bevel is up, and I put in the catheter till I know the tip of the catheter is at the tip of the needle before resuming. Then I'll hold the probe again and try to visualize the needle, and there now is where I'm ready to watch the catheter leave the needle. And you like to see it obviously go in a position where you're under, I like the catheter underneath the nerve. Here I'm still trying to find the needle, and I need the assistant to hold the probe so that you can identify the needle and the catheter going into the place that you desire. After you get it where you want it, I do actually, as I withdraw the needle, I put in a couple more. As I'm withdrawing it, I advance the catheter slightly, all the time watching it on the screen to make sure it doesn't go in a place that I don't want it to go. Here's again the needle you can see this bright needle, you can see the muscle, the nerve, and you want the catheter under, where I like to put it is underneath the nerve. And as you see, they're slowly withdrawing the needle. You can see the catheter again exiting here. The needle's being withdrawn, and you can occasionally, as you tilt the probe, you'll see the catheter here, and you can see the local going through the catheter, again lifting the nerve up. I will test dose every catheter because we don't want an intravascular catheter, so I'll take the 1.5 lidocaine with the 1 to 200,000 epi in the epidural kit, and we'll use the test dose. Here I'm shot air through the catheter, and you can see this bright hyperechoic catheter underneath the nerve. There's certainly different ways to attach the catheter. I feel that if I take a big bite of the iliacus muscle, that I don't really, we haven't had much retention problems, so I think I usually don't tunnel it. Also because the patients go home and they have to pull it out themselves, so I think it's harder if we tunnel it, so I generally don't tunnel it. And when I take the catheter itself, I coil it in a kind of a curlicue configuration. We spray it with something called liquid adhesive, which is we actually got from the colorectal surgeons. When they did hemorrhoids, they would tape the cheeks apart. We use that liquid adhesive, and I spray it right over the hole where the catheter exits, and then I put a pretty generous portion over the skin, and then I also put the stat lock that comes with the epidural to hold it there, and then I tegaderm over the whole thing. Well, that video kind of shows how we do it. Again, I've talked about adherence, how we, it's kind of frustrating if you put in a catheter and it doesn't stay in, so you want to do all you can to keep it. As I said, since we've been using this medical adhesive, we really haven't had much leakage or retention problems. That stat lock keeps it together, and basically we try to also stay out of the surgeon's way because they've also pulled out my catheter many times too. So now for a total knee arthroplasty, generally how we do the anesthesia is we put the femoral catheter in preoperatively. We also do a general anesthesia with an LMA. We obviously don't use as little opioids as we can. In the hospital, they usually stay 2 days. We do run them at ropivacaine at 0.2% at 5 mils an hour with a 5 mil bolus every 30 minutes. We tend to think that the bolus feature works better than having them have a straight infusion. We also do give them PO opioids, but surprisingly we haven't had to supplement many with IV opioids. Dr. Ilfeld did a comparison looking at IV opioids, epidural, and femoral catheters, and looked at all sorts of things as sorts of analgesia, discharge readiness, motion, side effects, and it seems like the femoral catheter was really the best option. So we've been pretty happy with it. The patients really don't have much pain, and so we do round on them, so I do see them the next couple of days, and generally they're a pretty happy crowd. For the ACL repairs, we do send them home with the catheter. We send them home on ropivacaine, 0.2% at 5 mils an hour with a 5 mil bolus every hour. You have to send them home with a portable pump. We use an elastomeric pump. We also give them PO opioids, and we leave that catheter in 2 days, and we instruct the patient on how to take it out themselves. I'll get into that in a little bit. For a fem block, we do use that and supplement to the sciatic block. For medial lower leg, foot, and ankle surgery, we sometimes will do a saphenous, but if we do want to do some of our surgeons want to do the whole surgery under just sedation alone. A lot of times they'll ask for a femoral block and they're not worried about the ambulation afterwards. So we'll do a single shot with 20 cc's of 0.25% bupivacaine. Now the saphenous, I call this rescue saphenous because one of our surgeons wants only a saphenous block for his ACL repair, single shot. But there are branches that are proximal to the adductor canal where the saphenous runs that help analgesia to the knee. So occasionally when we do a saphenous, a lot of times we've had a couple that haven't had adequate analgesia, so we will rescue it with a femoral block. The question is whether to spare the quadriceps, does that really have a little bit inferior analgesia or better analgesia as far as discharge readiness? That's still a question to be addressed. In any event, we will still rescue it if they don't have adequate analgesia with 20 cc's of 0.25% bupivacaine again. Again, I'll give you a caveat though that some people say they're question whether they should do another peripheral nerve block on another peripheral nerve block. We do give them post-op instructions if they go home with verbal and written, and a phone number to call if they have any problems. When they go home, we definitely don't want them to be weight-bearing. I hope all your patients after your femoral nerve block have a 0 out of 10 and are happy like this. And my son also thanks you. He likes doing femoral blocks on little soldier guys. And if you have any questions, please send me an email. Thank you.